Welcome, everybody, to our monthly webinar. I'm Chris Rogers. I'm a board-certified physical medicine and rehabilitation physician. I've been practicing in Carlsbad for, 25 years now. I'm joined today by my friend and colleague and world-renowned stem cell expert, Dr. Bob Harman. Thank you, Bob, for joining us today.
Good morning. Excited.
We're really interested in, this is going to be a really interesting conversation. I'm really looking forward to reviewing some of this information that so many people have questions about. Stem cell therapy is something we've been hearing about for a long time, but I think today our job is to help people understand the value it plays in treating patients with knee osteoarthritis. I'm going to go ahead and get started. So again, I'm Chris Rogers. I'm the kid on the left. And I founded a practice here in San Diego, realizing that regenerative medicine, this new emerging field where we were going to use cell therapy as a drug, as a treatment for osteoarthritis and other orthopedic conditions. So I'm really excited about that project. I'm also medical director for a company called Personalized Stem Cells, for which Dr. Harman is the CEO and founder of that company. And you're going to hear more about that in a little bit. But prior to that, Dr. Harman founded a company called VetStem Biopharma, which offers and treats animals in the veterinary medicine space using many of the same approaches that we will be using in humans. I'm going to assume that everybody on this call wants a happy, healthy, and active life. One of the great joys of living in San Diego is we have great weather and allows us to get outside and explore the desert, the mountains, and the beach and be active. I think we're also very interested in having a long, happy, healthy life. And longevity is a big interest in the media and in the science. And I want to start off with a scientific paper. I don't want to get in the weeds too much, but to me, this really tells a very important story. This is a meta-analysis study that was published in Lancet, a high-impact journal. I'm sure many of you have heard of the Lancet journal. And in this study, they looked at 15 long-term clinical trials trying to understand the relationship between being active and living a long, healthy life. And so they looked at more than 47,000 people. These studies covered more than 40 countries, so wide spectrum of people, and they tracked their mortality from death from all causes. So they tracked patients who passed away from cancer or heart disease, other causes, and correlated their activity level as measured by using a tracking device. So it wasn't a Fitbit, but it was a similar device. And they found that, as we would expect, that increased activity correlates with decreased mortality. And I want to highlight this point. You can see the graph on the right. There's two curves. The orange curve is for people who are younger than 60. The blue curve is a model that fits people who are older than 60. And for people who are younger than 60, those people who walked 8,000 to 10,000 steps per day saw a 50% reduction in their all-cause mortality. So a significant reduction in likelihood of death simply by walking. Everything else was controlled for. The good news for those of us who are now over 60, I'll be there soon, a few months, you didn't need to walk as much. 6,000 to 8,000 steps per day is pretty much where most of the benefit was seen in reduction in all-cause mortality. If you look at those curves, there is a slight advantage to going beyond that 8,000 steps per day, but it's minimal compared to that range that I've highlighted. So we want people to walk, we want people to stay active. And the single greatest reason why they can't do that is this problem right here, knee osteoarthritis. And knee osteoarthritis is extremely common. It's the most common thing that I see in my medical practice, with more than 30 million people in the United States suffering with knee osteoarthritis. 500 million worldwide is the most common cause of disability worldwide. We're seeing an increasing number of joint replacements done in the United States every year, with currently more than 1 million per year. I think many of you would be aware that this common symptoms are obviously pain in the knee with standing and walking. There can be joint stiffness, swelling, warmth. Sometimes the joint will make noises. I saw a lady today who demonstrated the noises that her knee makes, and instability of the ligaments can occur as well. And this is something that increases as we age. It becomes more prevalent as we age. And for those that are now Medicare age, 65 and over, about 1 in 3 of you If you go to your high school reunion, about 1 in 3 of your classmates will have knee osteoarthritis. So it's a significant issue. It's very common. And my concern is that it impacts longevity. This is what it looks like on X-ray. On the left, you see a normal X-ray. You see the thigh bone and the shin bone with a nice space between them. And as the osteoarthritis advances, as the cartilage degenerates, the space between the bones becomes more narrow. You see some whitening of the bone, which means the bone is being stressed. And so this is what we see on X-ray. You get a better picture if you look inside that knee joint with a camera, and that looks like this. So on the left, you see a healthy knee. On the right, you see somebody with osteoarthritis, and it's very striking, the difference. You can see that the articular cartilage, that smooth white tissue, is degenerated and the bone is exposed, which is where a lot of the pain comes from, that pressure on the bone. It's very painful. The other thing that causes pain, the lining of the joint, it's called the synovial tissue, will become inflamed. You see that red tissue in the right image there. That's the tissue that makes the fluid in your joint. That's the fluid that lubricates the cartilage and actually nourishes the cells in the cartilage. When I was in med school, I was taught that cartilage does not grow. And it never made sense to me because when I was little, my knee was only this big. And then I became a teenager and the knee got bigger. So clearly, cartilage is a living tissue that can grow. So this whole notion that cartilage is not a living tissue is wrong. But unfortunately, it's poorly nourished and has a difficult time regenerating itself. And so osteoarthritis is a slow deterioration of the quality of the tissue along with that inflammation. So now we're going to ask Dr. Harman some questions. Well, we're hearing that stem cell therapy might be useful for knee arthritis. So what's your opinion? What's your experience, doctor?
So we have a long history experience of osteoarthritis and problems. And before I launch into that, I'll give you another interesting piece of data that relates to what Dr. Rogers said earlier. There was a very nice published study that showed if you add to that person walking in the middle a dog on a leash that didn't have one, their activity level goes up. They lose body weight. They're less heavy, and their longevity goes up. So it helps the dog and the human. So it's a really nice segue into that. We have the exact same problems in dogs, cats, and in gorillas, and in elephants. All animals that we provide stem cell treatment for and have for the last 20 plus years. The first San Diegans to receive real stem cell therapy, this commercially, started in 2002, 2003, and they were first horses. I'm a horse veterinarian by original background, and then dogs, and then after that, we expanded into literally a whole zoo, and we do all the work for the San Diego Zoo, for SeaWorld, for the Birmingham Zoo, for the big zoo in Portland that has the rare wolves. So we work on all these rare and endangered species and some of the common ones as well to provide this kind of therapy. And so what is a MSC? What's a mesenchymal stem cell? What is a stem cell? What's regenerative medicine? It's the topic of today. These little cells, the little pink ones there on this beautiful photomicrograph, show cells hanging out on the outside of blood vessels. Every place in the body they're there. If you look at them under a microscope, and if you injure yourself, like with a paper cut or a more significant trauma, these cells are right there at the blood vessel. They come off, they become activated, and they become these really active stem cells. So what do stem cells do? Let's talk a little about this. So the recently departed Dr. Arnold Kaplan was a friend of all in this industry. He led the charge from 1980s to now, talking about what these stem cells, MSCs, mesenchymal stem cells, what they do. And they're really key in how we all stay alive, whether you're four-legged, two-legged, or whether you're a bird. We do birds too. These cells are drugstores, and they're adaptive. So if you place them in a location where there's a problem, an injury, they provide these little biomedicines to reduce inflammation, help modulate the immune system. They fight cell death. So for any of us that have a heart attack or a liver damage, these cells help rescue cells that might otherwise die. But really importantly, and direct to the point Dr. Rogers made, they help regenerate tissue. If you put them in a joint where you've got damaged cartilage, and they stimulate the little progenitor cells that are there in the joint to help new cartilage grow, which is what we're trying to do. But they turn off the inflammation, they reduce the pain pretty dramatically, and they cause this regeneration of tissue. So whether we're trying to make bone, cartilage, these cells can help repair damaged cells. And they self-renew, so they can divide during our lifetime and make more of themselves. So this is a video of 3 patients. And these are all patients of VetStem. These are just examples. So Maggie is an orthopedic nightmare. Dr. Rogers would not like to see a Maggie walking in the door. Maggie literally couldn't walk, had multiple surgeries, and both the veterinarian and the owner had kind of given up. But the owner said, hey, I think Maggie wants to try this. Could we please try this stem cell therapy? And with some reluctance, we said, okay, yeah, we can give that a try. Floppy, on the other hand, is a much more typical back pain, overweight. You can tell Floppy's about as long as she is wide, and clearly has trouble even rising. And we try to make the decision in veterinary medicine whether it really is appropriate to continue treating an animal, or whether it's time we make a decision that it's time to put them to sleep. You'll see in just a second, Floppy maybe gives us a signal that that she's still wanting to give this a try. She literally can just you go, oh. And we had tried all the standard pain meds and nothing worked. So Floppy's going to tell us maybe we'll give this a try, and so we'll see post. Malibu, very different. Malibu's much younger, I think at this time about 7 years old, but had really bad, what you've heard of as hip dysplasia. It's a hip that's not properly put together, and it's kind of floppy around inside the hip. Really bad pain, and had been on lots of pain meds. So now you got to remember what Maggie looked like before you judge this. This is not a normal dog at 30 days after stem cell treatment, right? It's not normal. But now Maggie can at least get around. There's a little bit of wag in the tail, and certainly improved. This is at 90 days. This is still not a normal dog, and she'll never have a completely normal, because there's some pathology there we can't fix. But look at the movement, the ability. Watch the tail wag. Now Maggie has, as Dr. Rogers suggested, maybe going to have a more active and pain-free life. And we'll talk a little bit about how the follow-ups on these. Floppy was a total surprise. Obviously, we didn't repair nerves in the back in 90 days. We didn't grow a whole new back. There was a really bad pain in the back, and so this treatment with stem cells dramatically reduced the pain and allowed Floppy to get around. Malibu now out at 120 days. Remember, this is hips. This is how they propel themselves and how they basically carry their weight. And now you can see Malibu really is having a spectacular ability to move, much better quality of life. And the important part, particularly for Malibu, for all of these animals, they had cells stored in liquid nitrogen in our storage system and could get retreated over and over again as pain maybe came back. So we have now treated more than 25,000 patients over the last 20 years, have cells stored for all these patients, and dramatic impacts on them, all kinds of animals, not just dogs, not just horses, not just cats, but all these animals.
How many different species do you have now?
61 different species, and it's 61. We used to have 60. Now we have 61 because of Dr. Rogers and running our clinical trials. Now we've added the two-legged people to the picture. Dogs really are that they don't lie. They tell you the truth. They're not going to give you a placebo effect. They're not going to make up stuff. If they're still painful, they will tell you. And anybody who has a dog, cat, or a horse, you know that to be true. They don't lie, and they give us a huge amount of data that we've now used, and we'll talk about. Dr. Rogers will talk about it in human, but there's now human studies from around the world showing that these kinds of cells that we've shown in veterinary works, that they really can work, and you get a really significant impact. And when we started this 20 years ago, there were not any human studies. Now we've taken all of our veterinary data and translated it into human clinical trials that we'll talk about. But this is now become a worldwide phenomena with approvals in other countries. The next slide shows you similar to the slide that Dr. Rogers showed you with the knee arthroscopy, but this is the before and after, not the normal and bad. On the left, Dr. Rogers, describe this, because this is a study actually you found in the big journal Stem Cells.
Yeah, so stem cell therapy is approved by the regulatory authorities in South Korea, and that's thankfully most to Dr. Joe, who published this paper many years ago, where he showed proof of concept. On the left, his patient's knee with severe knee osteoarthritis. When they talk about bone on bone, this is what we're talking about. You see the white fluffy cartilage has thinned out on many areas where now the tan bone is showing through. And then 1 year he went back with a knee arthroscopy and reevaluated these patients, even though they were feeling much better after a single injection of stem cells, by the way, from their own fat. These stem cells were from their own fat. Single injection into the knee, even though they were feeling better, they consented to have Dr. Joe go ahead and take a look inside, and thankfully be able to teach us that, yeah, my medical school taught me wrong. We actually can regenerate cartilage. And this is tremendous because we have treatments, cortisone injections are nice. They decrease inflammation, but they do not reverse the pathology. They do not promote healing, and therefore the results are not durable. And the reason why stem cell therapy has the most durable efficacy of all the non-surgical treatments is because you are actually regenerating tissue.
And so in 2018, after having done back then probably 18,000 veterinary patients, I actually ran into Dr. Rogers at a meeting where I was giving a lecture on what we do in veterinary, and we became close friends after that meeting. We had, I think, a 2.5-hour discussion after that meeting that day, talking about data and how we can use veterinary data, and we formed Personalized Stem Cells Inc. as a spin-out from the veterinary company, but with access to this, thousands and thousands of animals worth of data, safety data, efficacy data, data on dosing. And we took all of that data to the FDA, and we said, we would like to go into a human clinical trial, knee arthritis. And Dr. Rogers wrote the protocol, designed after other ones that we'd seen in the literature, like Dr. Joe and others, and went to the FDA, and they took them a couple of months to figure out what was this company with all this veterinary data. And then they got very excited that this was real data. This isn't mouse data in a vivarium at a university. This is real clinical data in a wide array of animals, multiple species, where we understood how this should work. And so we went into the clinical trial business and decided we would raise the standard for stem cell therapy, because there's lots of illicit and illegal people out there trying to sell you things, including in San Diego, on billboards on the freeway. And we wanted to do this fully by the FDA business. So we started down the pathway, and we realized a core portion of this was stem cell banking. And we call this Stem Insure. And so this is really the core of the business. And we have 70,000 samples banked from patients that we've done in veterinary over all of these years. And we just then translated that into human, where you can get a little mini liposuction. The little sample, the lipoaspirate, comes to our facility here in San Diego that's FDA inspected. And we manufacture for you, the patient, your own bank of these frozen cells that have a minimum of 12 million cells per vial. And then they're stored in these big liquid nitrogen dewars at minus 180 degrees, and they last essentially forever. They're in suspended animation. It's your younger self stored there. So from the day you get them stored, they don't age. We all age, right? We're all going to age. But having these cells that don't age, we can have them for next month, next year, a decade from now. And we can grow from this single sample that you donate to the laboratory for you. We can make essentially unlimited doses for the rest of your life for other things you might need to do. You also might be in for another procedure. You probably wouldn't be in there for a joint replacement with Dr. Rogers. He would have referred you to somebody if you needed it. But you're in there for a knee arthroscopy or a joint replacement surgery with a surgeon, or some other elective procedure. Any fat at any time from any kind of procedure where they have access to get a little bit of fat can be used. So you aren't even then getting a procedure to get your fat. But if you're in there for something else, you certainly can use this. So why would you want to store your cells now? Like why? Why does it matter? Why not? Wait a minute, I'm carrying this around. I can do this later. And that is true. But we age, our cells aged over time, and you're never going to be younger than today. And they're a little bit more potent when you're younger. In fat, they stay pretty potent. But then we can make cells whenever you want them, as many as you want. The most important reason is to store your cells while you're healthy. Heaven forbid you get cancer, you have to have chemotherapy, you get a toxin, you get some kind of a bad viral infection. It can contaminate all the cells in your body where then you really can't get them. Or you might have had an accident, now you're in the ICU, and they're not so apt to let Dr. Rogers sneak in the back door and take a little fat sample from you. They're not going to allow that. So now you don't have your cells. There's a huge amount of technology going on right now, development technology worldwide, billions and billions being spent for things like gene therapy, drug testing for your own safety. There's going to be lots of technology that's going to get discovered that your stored cells could then be used to take advantage of. And there is a way to have early access. So we're going through the FDA process. Dr. Rogers runs FDA qualified clinical trials. We had 9 investigators, right, Dr. Rogers, in our last go? Yeah, that were in our, from all around the country in our clinical trial. But there is a way through the Federal Right to Try Act, you might have heard it called compassionate use, where if you have a severe problem, like a knee that is so bad it really the only options left appear to be only surgery, where you might be able to get authorized for a right to try. And then if your cells are stored, there's no waiting. You can store these cells just banking them. So you might be in for another procedure and you say, good, I want to store my cells. I just want them there in their younger state. Or you can go all the way 7 steps around to having these cells already fully manufactured and ready to use in the case of an emergency or this right to try. So it's a really nice way to do that. So the programs for early access, I'm going to turn this back over to you, Dr. Rogers, to talk about how this really works and how a patient that would walk into your office might actually be able to get access rather than wait the next 3-4 years before we get a full FDA approval.
Yeah, so to get FDA approval, people are aware that we have to do studies on safety and efficacy, and we've already completed our safety study with some preliminary efficacy data, which I'm going to present in just a moment. However, we still need to perform larger prospective and placebo-controlled randomized clinical trials. So some of my patients will qualify to be enrolled in these clinical trials. If they are not a candidate for the clinical trials, say their knee arthritis is too severe or they have some other contraindication to be in the clinical trial, then I would explore on a case-by-case patient with a case basis with the patient to see if perhaps we should apply to FDA for one of these expanded access compassionate use cases, or if the patient qualifies for this Federal Right to Try Act, which was passed by Congress in 2018, we can explore that with you as well. I'd like to present our data real quickly on what we found. So our first study was on a product, and I don't want to get too into the weeds, but I would call this sort of a stem cell light product. So it wasn't the 12 million stem cells that we're going to do in our next study, but this was a smaller number of stem cells. I think we averaged about 1 million per patient. And we looked at patients who had very severe knee osteoarthritis. This paper was published recently. You can pull it up online in Stem Cells and Development Journal. So as Dr. Harman alluded, based on his 20 years experience demonstrating safety in animals, we were able to get FDA approval to conduct a study on 29 patients with moderately severe knee osteoarthritis. And these were patients, most of whom were told they needed joint replacement. They had failed standard of care, and so they were enrolled in this clinical trial. The cells were collected by myself and our other 8 investigators through liposuction. That sample was sent to our GMP facility in San Diego, where you can see the guys in the bunny suits are handling the tissue in a sterile manner, and then manufacturing cells in the lab. This is a technical slide, but stem cell therapy comes in many different flavors. If you just suck fat out on the left, and I apologize for my propensity to compare things to food, but I am part Italian, so everything is compared to food in my clinic. I tell folks that when you suck fat out, it's a collection of a lot of stuff. There's fat cells, there's stem cells, there are other cells in there, there's oil, a whole mix of things. I tell people it's sort of like a bowl of cereal. It's a bowl of Lucky Charms cereal. But really what we're after is just one part of that cereal. So if you rinse it and wash it, you can get what's called MFAT. If you then centrifuge it and digest it with enzymes, you get something called SVF. So now this is the one that we studied in our clinical trial. And then in our next clinical trial, we'll actually pull out the blue diamonds, which are the MSC cell, and grow them in culture so that you have millions and millions and millions of these cells, which are used for treatment and also banked for long-term future use. And this is what it looks like. You get a vial of pharmaceutical grade product, culture expanded MSCs, mesenchymal stem cells or multipotent stromal cells, whichever language you want to use. Autologous means it's your own cells. So we are not a proponent of using somebody else's cells, and there's a lot of reasons to do that. But the nice thing about manufacturing it in this way is that you get a standardized dose. And this is critical because we want to be able to predict outcomes. By having a standardized dose, we assure the quality, potency, and purity of the product as well as sterility. So therefore, we can go ahead and move forward with FDA. This is just what it looks like when it comes back to the office. So after it's manufactured, it comes in this dewar that maintains it at a temperature that keeps it frozen. So when it comes to our office, it's frozen. In about 20 minutes, it will thaw at room temperature. I will draw it up in a very small syringe. And then using the ultrasound guidance, we can direct the cells directly into the knee. And you can see there on the ultrasound, the white needle on the left going into the joint space. Simple Band-Aid, no surgery, patient's done. Patient will be sore for a day or two, perhaps, and then they are off to the races. This is our efficacy data. So we had patients complete a 42 questionnaire that's called the COOS. It's the most commonly used instrument for assessing efficacy. And we were able to demonstrate clinically significant improvement in about 3 out of 4 patients at as early as 3 months after treatment. What you're seeing there are 5 colored lines. Those are subcategories. So we look at activities of daily living. We look at pain. We look at symptoms such as stiffness or noises in the knee. We look at their sports activities, walking. We look at their quality of life. And each of those is scored based on how they answer the questions. And so on the baseline there in the lower bottom, you see the timeline. So at baseline, you can see the scores, and each of those 5 subscales are increasing at the 3-month time point. But really interesting is that it continues for out to more than 2.5 years. So we did a follow-up at the 2.5-year time point, and patients continue to see these benefits from a single treatment. No additional treatments were offered. There's no other injection on the planet that can offer this kind of efficacy. Patient satisfaction was also rated very high. 77% of the patients were satisfied or very satisfied at the 2.5-year follow-up time point. And I told you that all these patients were told by their orthopedic surgeon that they needed joint replacement. 78% of them were able to avoid surgery during that 2.5-year time period. Some of the patients did have surgery at 1 year, and they told us, 80% of the ones that did have surgery told us that had they had the option to have another injection of stem cells, they would do it because they were very satisfied at 1 year. But unfortunately, the way the study was designed with the FDA, we were not allowed to offer that second treatment. So I think going forward, that will be a part of the protocol for our patients. So that's our clinical trial. It's available online. There's 2 QR codes there if you want to learn more about my company, San Diego Orthobiologics, or if you want to learn more about personalized stem cells and how to bank your cells. So we're now at the halfway point. What I'd like to do is take some questions.
Yeah, and I can't see the questions on my side, Chris, so maybe you can see them
Let
on
me
yours. And
stop
while,
this
while,
here.
while you're grabbing that, I've also kind of, so Dr. Rogers used the euphemism, after you get treated, then you're off to the races. So you guys know that that's another veterinary term. We have treated probably more than 500 racehorses, including ones that have won the Kentucky Derby and the Big Dubai Classic. And so we treat them and they truly go off to the races, where there are people standing there that also got their knees treated. So veterinary human medicine is very joined at the hip, and really appropriate that we're able to use all this veterinary data to help out all of our human patients and to really move this along at a much more accelerated rate than would normally happen.
Great. So I see the questions coming in. For those of you who are not familiar with Zoom, if you look at the bottom of your screen, you should see a list of options. One of the options says Q&A. And if you click on that, you should be given the option to type in your question. So I do appreciate your questions. We have some coming in now. So the first question is actually not about stem cells. It's about exosomes. It says, are exosomes of value for injections? So, Dr. Harman, do you want to tackle it first, and then I'll give you my 2 cents?
Sure. So exosomes are literally excreted, given off from stem cells when they're growing or dividing or doing something. It's part of how they manage their magic of doing healing. They put out biomedicines. They put out these little exosomes that are full of DNA, RNA, and they are being studied intensely. Certainly not legal, and probably my guess would be it's another 5 years at least before we really understand how to use those as a biomedicine. But they are being promoted, sold illegally, around the back alleys of these places that are trying to prey on desperate people.
Yeah, my 2 cents. I agree with those points. There's excitement over the concept of exosomes because we're learning, as Dr. Harman uh, educated you earlier, a lot of the way that stem cells work is by communicating with other cells, and they do that through exosomes as well as other molecules that they secrete. They also do something that's really interesting that I love, and I just have to always mention it. Stem cells will physically attach themselves to sick cells. So if you have a cartilage cell in your knee that's sick, it's not able to function normally as a cartilage cell. The stem cell will attach itself to it and actually inject through a tube mitochondria and other cell contents that will help resuscitate that sick dying cell. So the stem cell functions as a very smart monitor of the environment. Exosomes, in my opinion, are not smart. An analogy that I heard is that exosomes are like text. So it's the actual content in the text, but you still need to have two human beings texting each other. So the stem cell in this analogy is the person. The text is simply the message. And so I think it's going to be a long road before we understand how to use exosomes properly as a
Yeah.
therapeutic agent. But the key
Yep.
take point today, if you hear nothing else about exosomes, is they are not legal in the United States. And go on the FDA website, they make it very clear. Exosomes are not an FDA approved treatment. It requires FDA approval. Why? Because we have to prove that it's safe and we have to prove that
Yep.
it's effective. And that hasn't happened yet.
Yep.
Next question. How can we apply for a clinical study and what is the timeline? We wish it was today. We really do. We have a protocol. We've spent a lot of time developing our phase 2 study protocol, and we're in the. If anybody is interested, just as a side note, we're raising money to fund the research. Research is very expensive, and so once we achieve that, we are getting closer every week. Then we will announce to patients that we are enrolling. Of course, we need the FDA to give us the approval to start the study, but I'm pretty sure that that's going to be a pretty easy hurdle to get over. And then we will notify everybody on this call, as well as other folks that we have their email, that we are enrolling patients. So we'll keep you in the loop.
Yeah, and our best guess is that we'd like to be able to start this trial before the end of this calendar year. So in probably late fall or winter. It takes a while, even once you get an FDA approval, to start the study, to get it all organized, and it'll be somewhere between 100 and 250 total patients. It's a pretty good number of patients, but the criteria are pretty tight. It needs to be really only one knee. It'll be knee only in this next clinical trial. And that probably leads into answering the next question, Dr. Rogers, about other joints and do the cells work there, but is that going to be in the clinical trial? So I'll let you grab that.
So not everyone will be able to get into the clinical trial, which is why it's important to have other ways to get treated. The next question is about ankles. It's something that's near and dear to me. My dear wife is suffering with some severe ankle issues right now. There's just a handful of published papers on the use of stem cell therapy for ankle osteoarthritis. The studies did show good safety and efficacy. These were studies done outside of the United States. The real interesting thing about stem cell therapy in my mind is how many medical indications it has the potential to positively impact. And that's because I told you the cell is a thinking creature. It's a living biological entity that is monitoring the environment and then responding in different ways depending on what the environment demands. So if it's a tendon, a ligament, a joint, doesn't matter which joint probably, it's going to respond. Our responsibility as scientists is to identify what I call the recipe. What's the right number of cells? Do they have to have more than one treatment? These are the little details that we need to discover. But to your question, yes, I do think it will be very helpful for ankle issues.
And I got to tell you, in veterinary, I think now the max number of joints we've injected in a single patient is 9 or 12. So we do ankles, elbows, hips, knees, and other joints, the hip and along the back as well. So we have lots of data that these cells, they're not like hip cells. They're really that they're going to broadly work in a lot of different kinds of joints, but the dose, how we apply them, that's all part of the learning process to know appropriately. And that's what FDA expects us to do. And that's what we intend to do internally as well. So we really understand it well.
The other thing that I will add is that makes me feel very excited about stem cell therapy is the safety that we have demonstrated in our study, as well as other scientists around the world have demonstrated, is exceptionally high. And there's concern. You hear people talk about, tumor formation or other things that doesn't really seem to happen with the use of your own MSC. There are issues with embryonic stem cells that you can read about, but with these particular types of cells, the safety profile is exceedingly high. So that's really attractive for me as a doctor to offer something that's safe. There's a question here, doctor, about cost. So I'm assuming the question is about the cost of banking your cells. If you're enrolled in a clinical trial, there is no cost. You're a research subject, and the cost is your time, and then the benefit is potential, benefit of the treatment. So for banking, there's two programs essentially.
Yeah. So one of the programs is you're just trying to bank your cells. You're going to do a little lipoaspiration. It might be for another reason. Perhaps you're getting your knee scoped and you could get access to that little piece of fat. The cost at the lab is $2,500 to get the cells from the box that comes in from your doctor into the freezer, and it's a 1-day processing. If you want your cells now fully manufactured, we can only charge what our cost is because this is not an FDA approved product yet, and certainly for the use under right to try, it's still an investigational product. Is $12,500, not plus 20. It's total of $12,500. That gets this between 5 and 10 doses manufactured in there, ready to go and use in an emergency sense or one of these right to try uses. We think as we grow this business and we're doing large volumes of patients, that base cost will even come down, but that's the cost today.
And just to be clear, that buys you a lifetime supply of your own stem cells preserved at the age which the cells were collected, which to me is tremendous. It's similar to what people do with their children with their umbilical cord, right? They bank the cells. It's just that the uses of your own MSCs are going to be far greater than
Yeah.
what the child can do with their umbilical cord, because they're only FDA approved for very limited scope.
Yeah.
I see you have treated dogs with hip issues. Do you also treat humans for hip issues? So yes, we have a couple of patients that have been treated under the Right to Try program. We've had very good outcome, excellent safety. I think we have one patient now who's what, 3 years out, maybe 4 years out.
Almost 4 years now. Yes.
No recurrence of pain in that hip.
But
Understand.
it's a very interesting one to talk about because she's going to see you next week, and for not injection in that hip from 4 years ago is still doing beautifully. She runs on the beach. She's a very active lifestyle person, and now the other hip that didn't get treated 4 years ago now has got its problems and progressing with osteoarthritis. And now under the Right to Try Act, we've got the ability to provide her treatment in the other hip. She doesn't have to get a fat collection. She's already had that done, already had her cells manufactured. So now they get used. They just come out of that freezer and she's able to get treated again. So it's a really good example of what we do all the time in veterinary. We're getting retreats. And I think, Dr. Rogers, you've had also several other patients that were in the clinical trial with you originally that have now gotten retreated as well.
Handful. Yep, that's right. Great. The next question is, it says, are you coming to Malibu? So I'm assuming you're asking not Malibu the dog, but Malibu the town, lovely town. I mean, ideally, so this is what I see as the future for this company and for stem cell therapy for the United States in general, is that we need the FDA approval for stem cell therapy. We need patients to understand that it's very easy to bank their cells and they should do it as soon as they can. Then we need the physicians around the US to get trained in proper diagnosis of the condition. And then if the patient is appropriate for stem cell therapy, the proper way to administer those cells. It's very easy. You saw that video. To inject the knee with ultrasound guidance, extremely easy. And there are many physicians who can do this. We just need to make the product available for them to use. The question is, can it be used to, so the point I'm making is, we're expanding our network, and we have a large network of friends, orthopedic surgeons, orthopedic medicine physicians such as myself, radiologists, plastic surgeons who can help collect the fat. We need to grow that network of folks. So if you have a physician who's forward thinking and is interested in the work we're doing, we'd be happy to talk to them, because I have patients who fly from the East Coast to see me because there's nobody available for them to see.
Yep. And Chris, to directly answer that question, one of your colleagues has asked that, and he said he's here in Malibu 1 week out of the month, starting to build orthopedic orthobiologics practice out here, and we're working with him right now to make sure he gets trained, onboarded. So we hope he will be able to provide people in the LA area that in the future.
Right. There's a question here. Can it be available to treat a meniscus tear? So as those of you understand, the meniscus is a little cartilage pad in your knee. You have two in each knee, and it's very common to tear them. Many of them can be managed with other forms of therapy, but for the ones that are more problematic, the larger tears, in the past, surgery had been recommended. It was called a meniscectomy, where, in the distant past, the surgeon would often remove the entire meniscus, or in their attempts to trim the torn edge would accidentally remove the entire meniscus, which is problematic because now you've removed a key component of the knee, which leads to an acceleration in that osteoarthritis process. So there are patients who need their knees scoped. I'm sure many of you in the audience have had their knees scoped and done well with meniscus tears, but the whole field of orthopedics is sort of the opinion that the surgery is overutilized and it's only for very specific cases. There's, to my knowledge, no published paper that directly compares culture expanded MSCs, stem cells, for meniscus tears, but there's a lot of basic science that shows that it's efficacious. I imagine you have some experience, Bob, in animal.
Yeah, for sure. So dogs with meniscal tears and horses with meniscal tears have been successfully treated. And as you would know, because you read every literature paper ever written, the first real MSC stem cell study in a meniscal injury, it was a study done at Tufts University in goats. And this is now, but nearly 20 years ago, and showed they could regrow partially removed meniscus with new meniscal tissue. And it just tells us these cells are powerful and can help repair various kinds of tissues. We just have to know how to apply them in the right way and in this sort of FDA methodology of stepping through this, according to the rules, so that we have really good data, so that the physicians that we bring on board around the country know the appropriate way to apply this technology.
I think that's exactly right. I think when we talk about evidence, I'm a by the book guy, so you'll hear me talk about published scientific papers. So in a perfect world, we have one group with meniscus tears who gets stem cell therapy, the other group gets a placebo, and then I can answer your question in a really intelligent way. But we have so much preclinical data in the lab. We have Dr. Harman's experience in the field with real animal patients. We have mechanistic data. So what I mean by that is the molecular biology of these cells and of cartilage damage in particular is very well studied. I won't bore you with the details, but right down to which microRNA are transcribed to turn on the genes inside the cartilage cell to manufacture cartilage. Very well. So we have good evidence in the basic science. That just needs to get translated into human clinical medicine.
Yeah.
On a more practical question, when should a patient get a second treatment? So what's your experience, Bob, with the animals?
So we have two sets of experiences. One is, which was not the right way to do it, but it's how we started. We said, let the animal tell us when they get sore. When are they ready again? And so the average dog or the average horse that got treated in a joint, in a knee or in an elbow, the quality of life improvement would last between 1 and 2 years. And then they would come back. And so, now you're walking your dog and they're getting a little reluctant. So they're starting to get pain. Probably the way this will be, and if you look at the initials behind my name, my MPVM is a master's in preventive veterinary medicine. I'm sad to say, in veterinary and in human medicine, we often are behind the curve and we're not really doing it preventatively. So the more forward-thinking veterinarians that we work with set a schedule, having seen what the real data is in thousands of animals and about when it's going to come back, and they will put it on the schedule and say, when you come back for your annual physical with your dog, just retreat again, because we know we're going to continually to get some degradation, and eventually this will come back, particularly if you have a conformation problem. You're going to wear and tear, or you play too much pickleball, I would guess. Maybe you're going to get some more wear and tear. So why not have a routine? And I think that's where we'll be in the future. This is going to be, once you start this program, keep your joint rejuvenated and keep it in a regenerative format, and not let it go back to the inflamed format. So it's my prediction of where we're going to be.
Yeah, we have to move towards a more preventative model.
Yeah.
The single greatest predictor of bad outcome with any treatment in medicine is getting to you too late. And so, for those of you who exercise on a regular basis, you're monitoring your body on a daily basis. You're like, oh, my knee's a little bit stiffer than it used to be, And that's the earliest sign, because cartilage is not innervated. There's no nerve supply to the cartilage. Even though the damage has started, a lot of times people don't feel it for a decade, until it becomes a bigger problem. So I think some kind of early screening, just like the dentists do, they figured it out. They realize, you need to see your dentist once a year. I think we need to do the same thing in orthopedics and probably other areas of medicine as well.
Yeah. And part of the good news is, if you didn't, and so now you've got a really bad joint, the data is very conclusive that we can help still those really severe joints. We just don't make them new. We're not making a bone-on-bone knee that's grinding and clicking when you come in. We're not going to turn that into a teenager's joint. We just aren't. We're working towards that. How do you make it better? but these cells are dramatically good, reducing inflammation in the joint, in the synovium, and improving quality of life. You just might need to get treated more often and just have a good expectation. We're not making this joint brand new again at that point in life. So yes, it can be used. Yes, have reasonable expectations.
Not brand new, but feel almost brand new. Some of these patients will, when you reduce your pain and inflammation, even with a cortisone shot, even though it's temporary, the pain relief is impressive. And the way these MSCs work is they secrete molecules, as you told us, are anti-inflammatory. It's just that they last years, not weeks.
Right.
The other issue is, I'll share with you two studies to answer this person's question. First study, these are patients with severe knee osteoarthritis, and they had repeat MRI after their stem cell injection. This was a study done by Dr. Kim and others in South Korea. Again, South Korea leading the charge with this research. But they repeated the MRI for the patient every year for 5 years. And they measured the thickness of the cartilage and the quality of the cartilage in the joint. And this is the first study ever to do that, to go out 5 years. And what they were able to show is that after a single injection of a high dose stem cell, again, this was patient's own fat stem cells, they were showed that year 1, there was improvement, year 2, more improvement, year 3, more improvement. So even though you're not boosting the treatment, the patient's still seeing healing occurring. At year 4, it would plateau. And at 5, there was a slight regression, although it wasn't back to where it started. So in some ways, we did make that cartilage younger and newer and healthier. And this is really the first study to show this. This is exciting. The other study I'll briefly share was done in Australia by Freitag and others, where they did do a booster shot. I think it was at 6 months, and they measured the MRI. And what they showed is in their study, there was a beneficial effect of doing that booster shot in their study at 6 months. What they answer, that it would probably be a case-by-case basis, I think, the practice of medicine. But I think on average, a year, 2 years, I think makes a lot of sense based on the degree of severity of the osteoarthritis. Here's a question about patellofemoral syndrome. So I don't know, dogs and cats get patellofemoral syndrome. It's basically the patella, is your kneecap, and the way it tracks on the femur, your thigh bone, can be abnormal depending on the muscle balance, depending on the ligaments, etc. This causes excessive wearing, almost as if your tires were misaligned on your car. One side would wear down a little bit quicker. It's the same sort of thing. So the cartilage wears down. I think we are going to enroll patients who have patellofemoral joint osteoarthritis in our study. What is the cost of banking your stem cells? You answered that question already.
Well, the annual cost, because there's another question further down that's the same question that I didn't say. If anybody stored their kids' cord blood, you realize that there's an annual cost, and it's anywhere from $300 to $500. For us, it's $400 a year. That's just to maintain, not per dose, but the cost per year to keep all your cells in storage. And I think sort of related to that, the question about what can we do, what's legal, I think is confusing, right, Chris? People are always confused what's legal and what's not. Today, it's completely legal to bank your stem cells. So you can bank them. We can also, from that initial sample, we can grow up your set of doses. We can prepare as if it was going to be delivered back to you ready to go. But at that point, that's as far as we can go FDA legal. But then we're allowed, again, by what Dr. Rogers already talked about, these right to try programs, compassionate use, ability to be able to use them earlier prior to approval. But anybody who says they've got umbilical cord stem cells or exosomes or bone marrow stem cells from a donor, that's all totally illegal. None of that yet is approved in the US. You can go ex-US, and there are some places, not very many that are really ethical and safe to go to, but it's not impossible. But we think the legality of this is going to come down in the next 3 to 5 years, that we'll get a final approval from FDA. Then everybody that's stored their cells and anybody that wants to store them can do that and then use them. And then Dr. Rogers will be turned loose to legally use them for the things we studied, meaning knee arthritis, but also for anything else for which there's reasonable data and he as a physician decides he wants to use. what is it, Chris? Half of all drugs are used off label because you only get a label for one thing, but then the physician gets to decide, yes, this will work in the shoulder, or this will work in the hip, and it won't be restricted to just use in the knee.
Yeah, I think the off-label use will exceed
Yeah, yeah.
the use in just the knee alone. It's just that knee is very common, and that's where most of the studies have been done around the world, and that's where we know it will work, and that's the quickest way to get this to be an FDA-approved treatment that then physicians can use for other indications. A lot of questions here I'm seeing, Bob. Can you use it for my hip labrum? Can you use it for my back? Can you use it, for all these other indications? I think this is where we have to say consult
Okay.
your doctor.
Okay.
There will be cases where it makes sense. There'll be cases where
Yeah.
other options might be more appropriate,
Yeah.
which is why I'm a huge fan of seeing a board certified physician who can properly diagnose you,
Yeah.
understands all your other treatment options. Those should be explored.
Yeah, and the physicians are using the data from the literature. Yeah, and I think Dr. Rogers has read every published study on the planet in regenerative medicine. I try to do the same. It's hard to keep up, but I can tell you, we could play name the disease, and if you give me a few seconds, or between the two of us, we can name a study that shows the benefit when used appropriately. Does that mean your labral tear makes sense to treat? That's a question for your physician, for sure. But the excitement and the reason we're in this is there's such a broad range of things these cells have been shown to potentially have good efficacy. It's, never before in the history of medicine have we had this kind of a adaptive cell therapy with such broad uses. It is why, so without going through the individuals, that we've treated 48 different diseases and conditions. In osteoarthritis is a single condition. Within osteoarthritis, we've treated dozens of different locations in the body. So we're gathering data, sometimes only in very few, sometimes we get better data, sometimes we run a study. So between what we do and what our colleagues do in terms of producing this really good data, that's what then as a physician you use to make your decision. Is this the right treatment for this patient?
Yeah, that's exactly right. And there are other options. I see a lot of questions about, and I get this in the clinic a lot. What's the difference between a PRP, which stands for platelet-rich plasma, versus a stem cell therapy? And the short answer is platelet-rich plasma is exactly what it says. It's platelets and plasma, which are cells and liquid from your blood that have shown to produce molecules that stimulate healing and decrease inflammation. But study after study after study shows they're more beneficial in milder disease. So for mild hip arthritis, mild knee arthritis, small meniscus tears, small tendon tears, stem cell therapy is exciting because it's able to handle the more advanced cases, the more severe osteoarthritis, the larger tendon tears, the bigger meniscus tears. So PRP is not regulated by the FDA. The devices that we use to make the PRP, the centrifuges that we use to spin the blood, to extract the cells, is regulated by the FDA, and the practice of medicine regulates that as well. However, and there's good data that shows it's helpful, but it's mostly for milder conditions. If it doesn't work, then that's when you would say, okay, now I got to go to something that's more potent, more powerful. When will this be available to everybody? There's a question, when will insurance cover it? God help us. I mean, don't get me started, but I think
let me give them hope, Chris. Let me give them at least hope, okay? Because I know you hate insurance, and so do I. In veterinary, we have insurance for dogs and horses. They're owned by the same companies, so the same insurance companies. So Nationwide and Aetna, they have a veterinary group. After seeing the really good data that we provided to the insurance companies on the outcomes, I think all but one of the veterinary insurance companies cover this. Your dog can get covered for stem cell treatment today. Sorry to say, you can't yet, but that at least gives us hope that, and we will be very involved in that as a company, providing the data that we know to your insurance companies. And if once they see that it's a good therapy, good outcome, and it's cheaper than a major surgery, we have hope that that'll happen. So, but we can't guess. But
I think it's great. I think it's great to have hope, Bob. And thank you for ending this 1 hour session on a positive note. It's why I wanted to invite you, an expert in stem cell research, an expert in veterinary medicine, who is really decades ahead of the human medicine, which is why all us human doctors flock to you at the meetings because of your experience. So thank you for joining us today. I really learned a lot, and I hope our viewers learned a lot as well. Anybody who wants to learn more, we're both available. We're obviously very passionate about this subject, so we're available to you to answer your personal questions. And you can do that by contacting us at the information that I presented earlier. This is being recorded. It will be posted on the San Diego Orthobiologics Medical Group YouTube channel, which is easy to find. You just search STOMG on YouTube. I suspect we'll also be posting it on the personalized stem cell website as well. So again, thank you everybody for your attention. Great questions. Hopefully you learned something.
Great. Thanks.
Thank you.